We shared recently about Sarah's miscarriage with baby number 4, and unfortunately for her, this pregnancy did not resolve on its own.
So, this is going to be a heavy episode all about what to do next after finding out you've had an early pregnancy loss. It's going to be heavy as we talk through the challenges that you might face and the ones I just went through myself. So, please know we're sorry this video has to exist, but hope it can be helpful to you or someone you love.
Yeah, if this is your first time meeting us, I'm Kurt. I'm a board certified pediatrician.
I'm Sarah. I'm a board certified OBGYN,
And
we
we
are
are
the
the
Doctors
Doctors Bjorkman.
Bjorkman.
Well, figured I'd document this because if it helps one person, then that's great. So I am going to do meso to medically manage this miscarriage. The idea of like randomly bleeding, cramping when I don't know when or have like any control over timing kind of sucks with the expectant management option. So have the day off, and what a better way to use it. So something I always tell my patients is, hey, don't do this at night because then maybe you're up bleeding and cramping all night and that sucks and then you're tired. And anyway, so got up, had some breakfast. I'm going to take some ibuprofen, and then I'm going to take the Cytotec. If nothing happens within about 4 to 8 hours of the first dose, you can do a second dose. So sucks. Definitely not how I was planning to spend the day. So here we go.
As we have with all of our pregnancies so far, we have been sharing as we go along. We shared a couple weeks ago our joy that we were expecting baby number 4, and since found out that I had an early pregnancy loss.
Yeah, which just sucks.
It does.
And the biggest suck of miscarriage sometimes is that the pregnancy doesn't always just resolve on its own.
Yeah, so this episode is going to focus on the options for what to do if you have had a loss in the first trimester, which could be a miscarriage, incomplete miscarriage, or an anembryonic pregnancy. And we did a deep dive on all things miscarriage definitions in this episode. We can link here.
So I guess one of the questions is, what happens after someone finds out they've had a early pregnancy loss? What do they need to do next?
Well, ultimately, the pregnancy tissue needs to make its way out of the uterus for things to reset back to normal. And there are 3 main options that we kind of think about to accomplish that. So the first option is expectant management, or watching and waiting to see if things do resolve on their own. Option 2 is medical management, or taking medication to kind of help speed the process along. And then number 3 is surgical management, or having a surgical procedure called a DNC to complete the resolution of the miscarriage.
DNC being dilation and curettage. Okay. Now, each one of these options has its own different pros and cons, as well as chances that they're going to be successful, right?
Yes. So let's dive into that next.
Let's talk about expectant management first.
Sure. So the watch and wait option. You found out your pregnancy failed and you're not sure you want to intervene. You want to let the body try to handle this on its own. That's the expectant management option. So with time, expectant management is successful most of the time. But the thing is, it can take some real time. So after 1 week of watching and waiting, about 30% of miscarriages will be completely resolved. And about 60% are completely resolved at 2 weeks. Another 20%, or a total of 80% of these miscarriages usually will completely resolve by 8 weeks. But that is a lot of time and a lot of mothers who are left needing extra help to finish this terrible process of completing this miscarriage.
Okay. There is some limited data to suggest that expectant management may be more effective in those women who are symptomatic, those who report already having tissue passage or
cramping,
have
bleeding,
ultrasound findings consistent of an incomplete expulsion, than those who don't have any symptoms, right?
Expectant management seems to work better if patients are having some bleeding and cramping already.
For some early pregnancy losses, it is more obvious, right? What's going on? There's going to be heavy bleeding, passage of clots, and what is termed these products of conception. If this is you, talk to your OBGYN right away. There can be times where the bleeding can be excessive and potentially put mother at risk, or even just having medical expertise to help mom going through this process a bit easier can be so helpful.
Yeah. Women sometimes worry that they will see a baby, but this really only happens with losses greater than 9 or 10 weeks. Importantly, though, if you have bleeding that is soaking a pad, front to back, side to side, for more than 2 hours, if you feel dizzy or lightheaded, or you have a fever greater than 100.4, you should call your OBGYN.
Yeah. The other important part for anyone who's actively having a pregnancy loss at home is actually making sure that the uterus fully empties itself and that there are not any retained products of conception or any of that tissue left behind.
Yes. And so how to accomplish this is different for geographically where you're at, your local OBGYN or family doc office. Some practices will say, hey, come on in, we want to do an ultrasound to make sure the gestational sac is gone. Sometimes they'll just do a phone call follow-up and have you kind of describe your symptoms and then trend HCG levels to 0. So it differs from place to place. There isn't a specific, this is the right thing to do to follow this up. So just talk with your OB about that. Now, while some women choose to watch and wait, some other patients prefer more active management, so using medications or doing something. This is a very good option for many who are just looking for some control, helping things pass more quickly and with a greater level of completion than just waiting.
Now, the least invasive of these active options is medical management.
Yeah.
Medical management for early pregnancy loss can be considered in women who don't have an infection, women who don't have severe bleeding, they don't have low blood counts, and they don't have another bleeding disorder. This is a good option for those who want to try to shorten the time it takes to have complete expulsion and resolution of the pregnancy, but would prefer to avoid a surgical procedure.
So when you compare medical management with expectant management, studies show that medical management of early pregnancy loss generally decreases the time to completion and increases the rate of complete expulsion of all the pregnancy tissue without the need for surgical intervention.
Yeah, so what actually is this medical management though?
So medical management is taking a medication called misoprostol or Cytotec, usually vaginally, to induce cramping and bleeding. You can take this medication kind of buccally or under the tongue, but studies have shown that that causes more diarrhea and doesn't work any better than taking it vaginally.
Gotcha. Now, there was a landmark randomized controlled trial done looking at misoprostol. The Zhang et al. Trial enrolled women in medical management protocol of taking a dose of 800 micrograms of Cytotec vaginally on day 1, with a second dose, the same dose, on day 3 if things hadn't completed by then. And then they offered kind of surgery if things didn't get better after that.
In the group receiving the misoprostol, 84% were ultimately successful in completing the miscarriage. 71% were successful with 1 dose, and then another 13% after a second dose. In this study, 16% in the medication group ended up needing surgery to completely resolve the miscarriage.
Okay, so 84%, or almost 7 out of 8, had completion of their miscarriage with medical management. So somewhat better than that watch and wait, which was 80% by 8 weeks. And definitely kind of helping things happen and maybe giving some more control over timing.
Yes. So there is a medication called mifepristone or Miffy that can be added. You usually take this orally about 24 hours before inserting the misoprostol. And this addition increases the likelihood that it works completely to about 91% or more.
Yeah, okay, so more than 9 in 10, great. And this data comes from a 2018 study done by Schreiber et al., published in New England Journal of Medicine, and one of our big medical studies. It was a randomized, double-blinded, placebo-controlled trial of 300 women that really showed that mifepristone pretreatment significantly improves efficacy of medical management for these early pregnancy losses as compared to just taking the misoprostol, the Cytotec alone.
Indeed. So if your provider offers mifepristone to you as a pretreatment treatment option. It is definitely something to consider. However, it is not something that all offices, practices have access to, and so it may not. And meso or Cytotec alone is very effective.
What should patients expect kind of going this medical management route?
Yeah, so patients are likely to have that bleeding again heavier than a period and potentially accompanied by severe cramping. We usually counsel patients that if you, again, you're soaking 2 pads per hour for more than 2 hours, you should call your OB. Just like if you're, expectant management, having a miscarriage on your own. Again, with this, surgery could be needed if medical management doesn't achieve complete expulsion. And I generally tell patients, hey, after you put that meso in, usually we expect kind of a crescendo of symptoms within about 4 hours generally. And it gets more intense and then resolves back down. So just to have that in mind. And sometimes you get no action, as we'll talk about, and you end up having to do another dose. One extra thing to expect with medical management is that usually your provider will bring you back within a week of taking that medication just to make sure that you have passed the gestational sac, as that's kind of how they looked at it in the studies. And so most of the time you can expect to come back for an ultrasound in about a week or so, just to make sure you're on the right track.
Well, absolutely nothing has happened. So I am back for a second dose. Sucks because we'd just like this to be over with. If you get there, you do it, you're like sad, and then again, ready for this to be over with, and here we are. No action. That's why miscarriage is so hard, because it often kind of just drags. Like, you're not pregnant, but you're kind of like, no, so not pregnant. And so it's just really sucky in between. So let's see if round 2 is what we need. Well, we are 2 hours post the second dose and still no action, which, we'll see what happens here in the next 24 hours. But I texted my OB and said, hey, what's your OR schedule looking like next week? Because I may end up needing a DNC, which would, blow, but then it would be done. So the saga continues. And it's really a quite terrible time had by all. Like, you're just in this set that you just want to be done. Yep, I'll be right there. And like, life goes on, and it's not something that you have like shared with a lot of people. And so you're just kind of like alone in your grief and sadness. And anyway, if you have found this video because you are going through this yourself, I'm so sorry, and it really sucks.
Okay, so that's medical management. Let's talk about that final option, the surgical management option.
So surgical uterine evacuation, called a DNC, or usually a suction dilation and curettage, has long been the approach for women presenting with an early pregnancy loss and retained tissue. This is the path we choose if patients who present with hemorrhage. They're really sick, hemodynamically unstable, low blood pressure, or they have signs of infection. Those folks need to be treated urgently.
So those with lots of bleeding.
Lots of bleeding,
Okay.
Concern for infection, sick patients that we need to resolve this quickly. Surgery does that. So surgical evacuation can be preferable in other situations as well. So if you have medical comorbidities like a severe anemia or a bleeding disorders where we don't want you to bleed anymore for a long time, some cardiovascular disease. And then many women prefer surgery to expectant management or medical treatment because it provides a more immediate and complete resolution of the process with less follow-up.
So how do you make this decision with your OBGYN? How do all these compare in terms of effectiveness or complications?
Studies have shown that all three options for management of early pregnancy loss all result in complete evacuation of pregnancy tissue in most patients, and serious complications are rare, no matter which one you choose.
Okay, and it seems like kind of as a primary approach, surgical evacuation, if someone chooses that, results in a faster, more predictable outcome.
Yes.
So that's maybe a big...
That's a pro, certainly. So generally you have surgery, you wake up, and 99% of the time, it's done.
Okay, but then medical management is very effective as well, with somewhere between 81 to 93% of failed pregnancies coming to complete resolution with medical management.
If you're in the same spot I was recently, it is important to consider the risks of all these options and to know that serious complications after early pregnancy loss treatment are rare and similar no matter which option you use. Things we worry about with all of them are heavy bleeding and infection. The rates of bleeding-related hospitalization are less than 1%, and that's really important to know.
Gotcha, but what about that infection piece? I feel like that's a big deal.
It certainly is, but this is also very rare, possible after any type of early pregnancy loss treatment. One systematic review found that infection was lower in the watch and wait method than after surgical evacuation. But either way, the overall rates of infection were really low, less than 1% to 2%. And so did not feel that this should push you one way or another because it's so low for either option.
Okay, gotcha. What about other issues? Like after a DNC, like they were doing a procedure to kind of clean out the inside of the uterus. What about like adhesions or scarring or things inside the uterus after doing that procedure?
Yeah, so clinically important intrauterine adhesion formation was kind of previously believed to be a very rare complication after surgical evacuation. However, following DNC after early loss, adhesions were found in just under 20%.
Okay, wow.
There's
So
some
1 in
new
5.
studies looking at this.
Okay.
Yeah.
And this rate of finding adhesions in just under 20%, or around 1 in 5 women, has been seen in other studies too. Notably, both in this 2013 study and the prior study we just mentioned from 2025. In these, most adhesions were mild, but some were moderate and some even severe.
So about 1 in 5 patients may experience adhesions after a DNC, and multiple DNC procedures substantially increases the risk even more.
Gotcha. So I guess what I'm hearing from you is that a DNC is very effective and safe for mom, but does maybe have some risk of creating some scarring, adhesions in the uterus. But, I guess, okay, there's some scarring, some adhesions. Does that end up mattering at all for future pregnancies or the ability to get pregnant again?
And that is a really great question, and something that until recently they thought that, hey, adhesions in prior miscarriage probably didn't significantly affect future pregnancies. However, this study from 2025 kind of looked at women who had had prior surgical interventions on their uterus, and there was an increased rate of things like preterm delivery, placenta accreta and previa, as well as peripartum hemorrhage and a need for hysterectomy. It's hard to say if the prior surgeries themselves or whatever it is that led to the women needing the surgeries in the first place led to these negative future pregnancy outcomes, but it does make me pause for a minute before jumping right to DNC if medical management hasn't been tried first and there aren't other factors that make a DNC urgently needed. They have done studies after patients have just had a miscarriage, expectant or medical management, where the uterus was not instrumented, and we also see adhesions. Okay, so it's not always just a DNC that does it. You can just get adhesions after a miscarriage as well. But
and you mentioned in that study, those women weren't all miscarriages either. They had a DNC maybe for other reasons.
The study that looked at adverse pregnancy outcomes, this more recent 2025 study, looked at one of the things they were looking at was miscarriage and a DNC for that, but some was a uterine septum resection or a fibroid removal. And so they looked at different reasons the uterus had surgery on it.
Gotcha, okay. So it seems like a really good point that DNC sometimes is absolutely necessary and can be life-saving for mom in certain situations.
Yep.
But again, medical management will work most of the time, somewhere around 90%.
Yep.
The other question that I know comes up that someone might not think to ask about right away is, what about like blood type incompatibility between mom and the baby, the pregnancy that was there? And if there's anything special that needs to be done with that. Should mom, after an early pregnancy loss, receive that medication called RhoGAM?
Sure. So this is if your RH type is some negative, so A negative, B negative, AB negative, etc. We think about getting RhoGAM during pregnancy to potentially prevent something called RH alloimmunization in a future pregnancy. And the short answer here is it is no longer recommended to test or give prophylactic treatment for RH negative patients, but the official language is it can be considered on an individual basis with shared decision making. This recommendation kind of has recently changed. It was just updated by ACOG, the American College of Obstetrics and Gynecologists, to match the WHO, the Royal College of Obstetrics and Gynecology, the Society of OBGYNs in Canada, as well as the Society of Family Planning, and the National Abortion Federation's recommendations to no longer test and give RhoGAM for losses less than 12 weeks.
12 weeks, okay.
The kicker here is SMFM, the Society for Maternal Fetal Medicine, still does recommend giving RhoGAM for losses less than 12 weeks. And so this is one to talk over with your doctor.
Okay, well,
Yeah,
it's amazing how much there is to consider sometimes, with a miscarriage.
Yep.
And kind of that suck of it doesn't just end.
Yeah.
Maybe we can end on a little bit of a brighter note. When can someone start thinking about trying to conceive after a miscarriage?
And the answer to that is kind of right away. There is no quality data. Sometimes I hear patients say, oh, well, my OB said I should wait 3 months or something like that. And there really isn't any data to support waiting after a miscarriage is a way to prevent another early pregnancy loss or some other pregnancy complication. Small observational studies show no benefit to delayed conception after early pregnancy loss. I tell my patients that, hey, once your period has returned, that's the physical sign that your body is ready to start trying to conceive again. But I also say, hey, sometimes your heart and mind take a little bit longer. So the flip side, important thing here, is if you've had 2 or more losses, we definitely recommend you see your OBGYN or a reproductive endocrinologist and infertility specialist for a recurrent pregnancy loss workup. We generally recommend no vaginal intercourse for 1 to 2 weeks after a miscarriage. There's again not data for this. This is just thinking, hey, the cervix is open after passing that tissue and theoretically may reduce the risk of infection. Again, not evidence-based, but just that's the rationale there.
Gotcha. Okay. If this is you, this is a tough road. It's not easy. No one kind of tells you how to go through this process of grieving and how to work through it as a family with your partner either. And there's so many little dynamics of, man, we had a pregnancy that was maybe really desired and now you have to manage it.
Now it's not here, but it's not completing here on its own. And, the Cytotec didn't work. The first time I was on the schedule for a D&C, talking to the nurses, you got to be here at this time. Don't drink after midnight. Yeah. So it's just a lot in the midst of a lot of sadness. And, your providers are there to support you.
Mm-hmm. Okay. So in real life, management of a miscarriage.
Yes.
Do you my 2 cents is probably all I'm going to share. It's just I think this is where it's like a double suck of the pregnancy's over and now you have to take care of it.
Yep.
Yep.
So, I found out, hey, there was no heartbeat. Body clearly hadn't figured that out yet. Hadn't had any bleeding, cramping, anything like that. And then was like, well, after confirming that, in fact, there was no flicker there. Now what? Knew my options were watch and wait, try some meds, have surgery. So for me, I was, I counsel patients about this multiple times a week. The watch and wait option wasn't particularly exciting. The idea that the body handles this on its own is nice, but like, I didn't want to start bleeding in the middle of a patient visit. I had to travel for work. Like,
just life is happening.
Right.
Like, can you have any control over
that sounded
a terrible situation?
Right. And wanting it to just be done, like want this to be over, want to grieve, want to move on. So that very much made, hey, the medication option seem very appealing because, again, when you find this out, it really sucks, but it's not an emergency. So I scanned myself on a Tuesday night, had it confirmed on Wednesday, and then did meds
Friday,
Saturday. Yeah, like over the weekend.
It was going to be a long weekend for us with
Yeah.
us home together, actually.
Yeah, and so I said, cool, this sounds like a good, we're off Friday plan. Let's do this Friday morning.
We're not really watch and wait kind of people. either.
Yeah.
Just to know yourself and
Yeah.
know what you need and
Yeah.
just
So, feeling like you have some control over this sucky situation. So got some meso and, kind of shared along the way. You take those 4 pills, you shove them up as far as you can, and you wait. And usually you get some action in, 4 hours or so is what I always counsel patients, and nothing happened. It was just nothing. This is annoying. So then after that didn't work, I said, well, let's do dose 2 and hope that it works. And again, it was really not much happening. I did not have like really bad cramping, didn't have much bleeding. Kind of day 2, 3 started to just have this slow bleed, just this slow burn of a bleed, not super crampy, not whatever. And I texted my OB and said, well, I can't, what's your OR schedule look like this week? I think I'm going to need a D&C. And she got me on the schedule, and over the next couple days, the bleeding just kept happening, and finally it would pass a couple big clots, and then finally a bigger chunk of tissue. And I said, I think that
was it.
I think that's it. And so I scanned myself, again, just looking to make sure that gestational sac was gone, and it was. And so at that point, when I saw that the sac was gone, I was like, well, this was much less eventful than I expected, like less drama than I was planning on. But the gestational sac was gone and the lining was still kind of thick, but I said, well, we'll just give that time. I will say that I felt like this was atypical. I have had patients who were in so much pain they called 911 and went to the hospital. They were really, really uncomfortable. And so I always prepare my patients for the worst. I say, take Motrin ahead of time. Here's some nausea medicine. Here's some strong pain medicine. So I was prepared for war kind of, and it was much less dramatic than that, but it worked. And so I was thankful to not have to have surgery, just because that was going to mess with my day. I was going to have to cancel a whole full day of patients. And I also do, as I have seen patients who have really bad adhesions, and to caution and encourage people who do go the D&C route, your OB knows that, hey, this is a risk. We are so gentle and delicate with pregnant uteruses, people who have been pregnant, because it just tends to scar better. So it's just we're very delicate. You don't do more passes than you need to. You suck that tissue out and say, hey, we're done here. Because we want to be so careful and make sure your uterus is okay. So I wouldn't want to discourage anyone. That is very much the right choice for many people, and that's great that it exists.
One other little angle question thing that I thought, what do you do with this tissue?
Oh yeah.
Right, like you said, after 10 weeks you're actually seeing something that looks like a baby, and this doesn't look
Yeah,
like a
just,
baby
if you
yet.
look at the ultrasound, it was, it's a little.
It's, it's 7.
6 weeks. It was,
Yeah.
6 millimeters, half a centimeter,
Yeah.
and just.
Yeah, and so like, what do you do? Like, what do you do? Like, it just like we have emotions attached to this,
Right.
and like had plans and hopes and dreams, and so, if like, I don't know, I imagine it's a little bit different for everyone in terms of like, what do you do with this tissue that was like your dream of a child in a life, and so, I don't know, we like kept it. We're gonna bury it.
I don't know.
And just like, it's just like it didn't feel right to just get discarded either. And so that's something that I imagine is different for every one of you. For us, it was like, oh, like this is not just tissue. I don't know if that's safe to say.
Maybe, more. It was a little more, I think, for you. Something you can do sometimes if you've had multiple losses. You can do genetic testing on products of conception, and so it's called, one of the companies is called Honora, and you can get a kit. So if this is something to consider, and in that kit there's like a little strainer, like in terms of like
To catch it.
just catch it when you are,
And then you
using
can
them.
send that tissue in to say like, hey,
send that
was there
tissue off.
anything genetically abnormal about
Correct.
that
Yeah.
that pregnancy that like might help you understand risks of future pregnancy loss?
Yeah, so I had like a kitchen strainer in the bathroom.
I didn't know that. Okay. Did you wash it?
Obviously.
Okay. So anyway, this process is not fun.
It's not.
And I was just watching.
It's not glamorous, and it's, so that was how it all went. I'm still waiting for my pregnancy hormone to go back to 0. The bleeding has finally just kind of stopped after, I don't know, probably a week or so, 2 of taking the meds. Like slow, spotty bleeding. Pregnancy test, I'm kind of waiting for it to get back to normal or negative, and it's still like faint. So we're getting close.
Yeah.
And yeah, it's just sad. And it sucks. And so if you find yourself here, sorry you're here. This is a non-exclusive club. But it, has wonderful people. And we will hope for your rainbow in the future.
And we hope that kind of as you think through the options, just going into that conversation with your OBGYN about, hey, should I watch and wait? Should I try medications? Do I need to jump to a surgery for any reason?
Yeah, and I think most of the time, there's not urgency, right? If you're bleeding, if you have a fever, if you're hemorrhaging, that is urgent. That is a different situation. But a lot of the times, as I talked about a little bit, hey, we found this out. Nothing is happening. The body is a little behind figuring this out. And so we have some time to talk about this and think about this, or take the medication on a Saturday, because that's slightly more convenient than, a day in the middle of the week. So it sucks. It's really common, and
we hope this helps.
yeah.
So,
Questions, concerns, thoughts, leave in the comments below.
see you next week.
Sending hugs. Bye.
We're doctors.
But not your doctors.
Anything we've said in this video is for education or entertainment purposes only.
It is not medical advice.
Any specific medical questions you have should be directed to your provider.